set. Meeting will come to order. For public information, the Nebraska Open Meetings Act is posted in the back of this meeting room on the east wall. If anybody needs to see that or read that, it's back there. Next item is roll call.
Harris,
Here?
Meyer,
Here.
Reisig,
Here.
Blue,
Here.
Parsley.
Here. Should we introduce?
Yeah. So we are excited. This is the first meeting that Mr. Matt Parsley has been here, and the new commissioner, and all sworn in and ready to go. So we're looking forward for him to be here, and we're excited about talking about some of the things tonight that I know we have committees and things that we'll be discussing in our next meeting, but anyway, just wanted to say welcome to you.
Thanks.
Yep. Okay, let's all stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I'm
Okay.
not sure whose these are, but you and I are gonna share 'em. I'm glad you're willing to share. I don't even know.
I am gonna mention, a couple of the announcements that I normally talk about. Wanna remind everyone that this meeting is being recorded to be broadcast at a later date. So a couple things with that. Number one, remember that whoever wants to speak, be sure that when you're recognized, you come forward, state your name for the record, spell your name for the record. It'll help the clerk get her minutes correct. Remember, there's no swearing or any other inappropriate language. We all need to check our cell phones, including me. Be sure they're either turned on silent or something that doesn't interrupt the meeting. Also want to remind the commissioners to be sure and speak directly into your microphones so that our voices can be heard on the recordings as well. We'll see how long this meeting takes. Somewhere maybe about midway through, we may take a recess if we feel it's needed. And I think that's it. The next item is approval of the agenda and consider modifications, and I should mention that we intend for this to be one meeting, to be adjourned, and then we'll start our 4:30 meeting, so it's two separate meetings, and I just wanna be sure we all understand that. Anyway, so, next item is approval of the agenda.
Do you have something, Matt?
So this is the agenda strictly for the 2
Insu-
o'clock.
Yeah, the 2:00 insurance, item,
I entertain a motion to approve.
Second.
okay? So we have a motion and a second to approve the agenda. Any other discussion? Hearing none, Connie's gonna call the roll.
Parsley,
Yes.
Blue,
Yes.
Harris,
Yes.
Meyer,
Yes.
Reisig.
Yes.
Okay. Just wanna mention that the board reserves the right to enter into closed session if deemed necessary. We don't have anything on this agenda that I know of that would be necessary, but we always reserve the right to do that. We'll go on to the general agenda items to receive a presentation regarding health insurance. Ms. Lisa?
Good afternoon. I'm really happy to see our employees that made it to the meeting too. I sent out an invite Friday afternoon. I think you'll be really happy with the information we're providing. And with that, I wanted to introduce you all to the Alliant and Aplos team. They, the Aplos gentleman came from Des Moines to be here, and Ian came from Alliant Insurance Services, came here from Omaha to present this, our proposal to you. So, anyway, let me, BJ and Ty from Aplos. That is what we would anticipate our plan would be called in the future. And Ian from Alliance, I think he'll be doing the lion's share of the talking today about what we're presenting. And gentlemen, this is our board. I think as you can see, their names are up there. I have Mr. Reisig, Mr. Blue, Mr. Harris, Mr. Meyer, and Matt Parsley, and several members of our employees. So, that's about all I have to say. So, you starting?
Yeah.
And this is the right, I guess, and I have been talking to you all about meeting Ian at the NACO conference last year. This is Ian that I met at the NACO conference, so,
Okay.
anyway, here you go.
Thank you, Lisa. I'm gonna try to keep it under 3 hours. Health insurance is incredibly complicated. And some background on myself: I'm a Nebraska native from Fairbury, Nebraska. I've been in the health insurance space for 10 years now. Was the president of a firm out of Lincoln. Recruited to Alliant, where I'm at now, 2.5 years ago, and I work exclusively in public sector. So counties, cities, schools, Nebraska, Midwest, Georgia, Ohio, so throughout the United States. I'm a consultant with Douglas County, so largest county in Nebraska, and I do some on the smaller side as well. When I first was introduced to Scotts Bluff County, and we got a look at the current enforced benefits, the current health plan and the things behind it, it is a self-funded medical plan, and it would take a lot longer than 3 hours to explain how self-funded medical plans work and how they all integrate and the pieces behind them. But the way that it was projected, and the way that that you budget a self-funded medical plan is through projecting claims, because we never know when we're going to be diagnosed with something. We never know what's coming in any given year. And so all we can do is take the experience that we have in our data, and we can make a judgment call onto what that's going to look like this next year. And that's how we try to budget for medical plans. Well, when I looked at the claims experience, that was, this is about June-ish, May-ish, it was on a trend. So it was trending towards meaning that if employees continue to have the medical claims that they were having at the current medical setup that was in place, it was going to be about $1 million over budget. If on the worst case scenario. So if those claims continue to happen, if we started to see an uprise in high cost claimants, it could be $1 million over budget. So we knew that we had to do something. We knew that the current setup wasn't going to be sustainable. It was a self-funded model. There were 3 lasers that we were looking at in July, and for those of you that don't know, a laser is essentially a separate large deductible for the county to take on. So there are 3 high cost claimants that had their very own deductible that was over $100,000 each. That's $300,000 of additional liability that the county was facing, where they would have to pay that. The county would have to pay those claims if those occurred. We were able to stop those lasers back in July and get rid of them, to where there was that additional $300,000 went away, and that brought us to January. So it bought us some time, but we still need a better solution than what's in force. If we continue at the plan design that's in force, it's probably going to be about $1.25 million more than what it was this last year, which is a significant amount of money. So we did an exhaustive search of the market. We quoted all your Blue Crosses, your Uniteds, your Aetnas, your Cignas, the fully insured stuff, the stuff that is filed at a state level. That doesn't matter how your claims experience is. Everybody pays the same rate depending on zip code, gender, and date of birth, regardless of the employer that you work with. So we looked at those. Those were going to be a little bit less expensive based on projected models if we stayed where we're at. So that was an option to go to a fully insured. That's what that's called. And Aetna was the insurance carrier that was the second best. And then we looked at staying in a self-funded model like you guys are in now, but maybe finding a different stop-loss carrier or a different TPA or something around those sides. And we found a more favorable option. So Aplos, who I was lucky enough to have the founder and CEO join us today, and I'll let him speak on some of this. Aplos works with counties, hospital systems, providers all across the country as well. They are a little bit different of a model, and it's one that I can appreciate. It's one that I think the direction of medical, especially for public entities, is going to have to go. it is a self-funded model, kind of like we're in currently, so that is nice for the administration because they're used to that self-funded model, so it is still a self-funded model. But right now, your average discount at a provider is roughly 15 to 20%. Aplos gets, their average discount is 70%. So significantly higher savings on the procedures that employees are going through. So if you're an employee of the county and you have to get a surgery done, you're getting an average discount today of 15% on that procedure. We're looking at cranking that up 5 times, getting 5 times the discount on that to again, hopefully bring in lower costs this year. We want to be $1 million under budget, not $1 million over. And we want to create a surplus so that for the first time in a long time, we can create savings for employees and the employer. Now it's going to require a carrier partner that's creative in their thinking. They negotiate with the providers in the area, and they have the biggest one, because 5%, that's it, just 5% of the population that work for the county are taking about 90% of the cost. And that's very common. And nobody, nobody asks to be diagnosed with an ailment, nobody asks to get that, so we feel for those people, but there has to be cost containment strategies, there has to be an actual strategy to save money, or it's gonna get out of hand. And so a lot of the claims in Scotts Bluff County are coming from the pharmacy side, specialty drugs that can cost $1 million a year just for treating an ailment. Well, Aplos has a very strategic procurement process, which is going to bring significant savings, on average of 50% savings to the pharmacy, and that is what's going to put us into a good place, not just for this year, but hopefully for years to come. Put us in a spot where we can actually have, one, we can own our claims, we can own the data, we can get into a better cost containment strategy, and then as employees, we can equip all of the employees with a better product and more resources. So employees will have telemedicine that's virtual right there at their phone that they can call anytime they need something. So they have the ability, instead of having to go into a facility when they've got strep throat, they can get it done right then and there on their phone. Prescription sent to wherever they want, picking it up. Things like that make that simple. We'll have behavioral health at their fingertips. Same thing. They can pick up their phone, go into their app, and they can speak to a therapist about whatever's on their mind. So because that also is a big cost driver. We need to make sure that we have resources that are not just helping you with physical elements, but with mental ones as well. So the resources are there. And just putting together a strategy that's going to be user-friendly, informative, and work with employees where they're at. Employees right now that are seeking infusions, there's some that can't even get them at the local hospital because the contract's not favorable, so they're having to drive to Torrington, or they're having to go to Colorado to get those infusions. Aplos has a way of negotiating those contracts to where we can either get them done here locally, or even better, bring them directly to their house. Have a home health nurse bring those infusions directly to the employee's house, so that they're not driving and then sitting on a hospital bed paying $30,000 for an infusion that could cost $5,000, and they can feel a lot better getting it done in the comfort of their home versus going and getting an infusion done 30 minutes away and then having to drive back, and who knows how they're going to feel after that infusion. So it's things like that. We're actually looking at the employee level and the employee experience, as well as what this does from a cost perspective. So I do have a little bit of a slide that just kind of explains Aplos. I don't want to take too long on it and waste your guys' time, but just so you guys can see kind of how it's broken up. Just like a self-funded plan that you guys are on now, there are layers to it. Aplos is the overarching layer, and it means simple. Is that right? Yeah. Simple in Greek. That's what Aplos means. So it means simple, and what it's doing is it's taking all of those components that you guys have now, the TPA, which currently is RCI, it's taking the PBM, which I can't think of the name of that PBM currently. It's a smaller one, which is a pharmacy benefit manager, and it's taking the stop loss and it's putting it all under one window, or all under one thing called Aplos. And so inside Aplos, you're going to see there's some things here. Vivid Clear RX at the bottom, that's the PBM. That's the pharmacy benefit manager for all drugs that are under $300. So if it's a pharmaceutical drug that's under $300, Vivid ClearRx is the pharmacy manager that's doing that. All that means is if you guys are having if you get strep throat, you need amoxicillin. Well, that drug is being ran through Vivid ClearRx, but you can still go to your Target, you can go to your Walgreens, you go to wherever you need, you're gonna get that amoxicillin. But any drug that's above $300 in cost, there's a special procurement strategy that's gonna deliver that drug right to your door at $0 to the employee. So right now, where those employees might be paying $300 a month for that drug, $500 a month for that drug, they're now gonna get it for $0. Anything above $300 will be procured from a special procurement to where, because we're getting more favorable costs on that, the incentive to the employees, they're gonna get it sent to their house and it's gonna cost them nothing. And it'll be there when they need it and they won't miss a treatment. And so that's something that's gonna be favorable, but anything under $300 will be ran through Vivid ClearRx. Pharos, you'll see Pharos on there, powered by Ocunet. That's what you can consider the network. So you might think of a network as Aetna or Blue Cross or Cigna. When you go to a doctor's office, they ask you, well, what network are you in? You can use Pharos by Ocunet. So it's an open access network, which is a little bit different. You know, Blue Cross has the Blue Cross network, and you're only allowed Blue Cross. And they really try to move you to Blue Cross. Cigna, same thing. You're really only allowed Cigna. When you use an open access network, you're allowed to go wherever you want. Now there's going to be more favorable rates at a better contract negotiated provider. And so there'll be a provider search just like with anything else, just like with Cigna or Aetna or anything like that. So employees will be able to see where the more favorable providers are to go to. But they're still allowed the freedom to go anywhere. There's no more of being turned down at a facility because they're not in network. They're still allowed to go wherever they want. The other thing you can see, like Ocunet, this is just showing that they're the real deal. They actually do all of the contract negotiating for a lot of NCAA, the major leagues, NFL, NBA, WWE. So they do all of those. So they're large and they're a national network provider. This shows what that provider search looks like. So for employees, they can go and they can search this. And they'll see all of the providers in the area, and if they're in a green tier, which is an acceptable one, that's where we want to push you guys towards because it's going to be better for costs, or if there's a red. Well, we did a provider disruption report, so we took all the providers that the employees of Scotts Bluff have went to in the last year, and we ran it through their system. Only 2 of them came back red, and they're very minimally used. The rest of them were all green. And I think there were maybe a couple orange, but very, very favorable in terms of provider disruption. There were more on the green side than what's currently being used. So there will be less out of network to say utilization on this than there is currently. And then the last thing I want to show is just this card. So this just gives you an example. Everybody will get, or I'm sorry, where's that card? Everybody will get a card that will look like, I thought it was on here.
Maybe it's not.
Well, it looks like any other medical card that you have.
There it is.
This is just this is an EOB, so this is what you get from the statement after you've done your procedure. But the medical card looks like a regular medical card. It will just say Aplos on it, and then it'll have the pharmacy right underneath it, and then it'll have a call center number, just one phone number. That's a huge difference to where you guys are used to now. Currently, if you were to look at a medical card now, there's multiple phone numbers on the back. You need to talk pharmacy, you call this number. You need to talk to claims, you call this number. You need to talk to somebody that's, if I need to speak to somebody about my bill, I'm calling this number. You've got one number. The employees of Scotts Bluff have one phone number to call when they have questions about anything. It's a locally based call center that's taking that call, and they'll be able to help them with whatever the question is. So it's a one-stop shop for that, which will be a better experience. It's really a white glove concierge service, and that's what we're aiming to do. We're looking for cost strategy, but we're also trying to provide a better experience. Go ahead.
Ian, what do you mean by locally based? You said a locally based
yes,
call center.
Midwest based.
Midwest
Midwest
based,
based.
okay.
Yeah.
Not Scotts Bluff based.
No.
Okay,
No,
I didn't
not
think so,
Scotts Bluff.
but
I don't know. Do you guys have anybody that's working on it?
Des Moines.
Des Moines.
Des Moines, okay.
Yeah. Good question. Yeah, Midwest based. But it's not overseas, and it's not coming from, California or anything like that. They're Midwest. And they're willing to answer that call and address those members with whatever those questions are. And BJ, Ty, is there anything you wanna add?
No, do I need to get up and?
You should stand close to the mic.
Okay.
Ian hasn't been speaking into the mic, but I do like that he's addressing other people.
Well,
I do
yeah,
like
I'm sure
that.
it's picking it up, yeah.
Yeah, but I
It'll
hope
be
it's,
alright.
yeah.
I can start speaking
So,
to that.
I-
BJ Spikesman, do I need to, I wanna follow your directions.
Yeah, kinda, you
SP.
want it for the record?
Yes, please.
SPYKSMA.
Thank you.
So I wanna just take a quick brief history of what Aplos, when we started this, we came to the Midwest and we partnered with, has everyone here heard of Hy-Vee grocery stores? Yeah. So we partnered with Hy-Vee, so they're a 50%, they're technically 25, but we have a clinical team of, called exemplar care, they're direct primary care. So half of our ownership is a clinical provider group. And that is really who does our customer service. We start with people who have a clinical background, and they're our one-call team. So if you're in Omaha, if anybody from Scotts Bluff is in Omaha or Lincoln, and they see an exemplar care, or Kansas City, Des Moines, you're able to go to those at no cost. It's part of your plan here, but they are part of the ownership of Aplos. And so we take some of the folks that are on the clinical side and we put them in our call center so that they have knowledge of how clinics work, so that they can also help your members and your employees get appointments. If, right now, one of the most difficult things when you have a referral is finding some place that can get you in, right? So we have our own clinical team that will help do that outreach to help that member get an appointment. Because it's great now, I have an appointment in 6 months, I don't know what I'm doing next week, well, let alone in 6 months. And so by having an advocate there to help you get an appointment and see who else is available, that becomes very important to the member's experience. Did I answer? So,
Okay.
Go ahead.
No, go ahead.
So we really focus on that. We don't have time to go through the full app of what the member experience is gonna look like. But now your provider guide, your member packets and everything are built into your app that you're gonna be able to use. You're gonna see all your accumulators so that you can see where you're at with your deductible and your copay. Zealous is the one that powers this. Zealous is the giant in healthcare from a data perspective. They're the one powering our member experience. And so hopefully you're gonna have the state of the art, but we also know that healthcare is very personal. So to have an advocate there to call and talk to, even though you have, a great digital experience, makes the experience even better if you have somebody to talk to, so.
BJ, could you speak to the pharmacy for somebody on a specialty drug and just exactly how Atlas uses it? And you can use the example of Humira. For those of you who have watched, anytime you watch a commercial and you see those really happy families that are getting that drug that's in the corner of that screen, you can pretty much assume at a minimum that costs $100,000 a year. And so I don't think that family's as happy as they're showing in that picture. But you can assume it's about $100,000 a year. And Humira, for instance, is a drug that not only impacts Scotts Bluff County, but impacts pretty much every employer I work with. It's going to be if I look at a self-funded claims experience for a client, I can, without even having to see the drug list, I can tell you that that's on there. That's going to be one of them. That or Skyrizi or one of these really common ones.
I hear about Monjaro a lot lately.
Monjaro, all these ones that are hitting the plan for a lot of money. And so we knew that we had to stop the hemorrhaging somewhere, and we still have to. And this is kind of, we talked about this last night, I think in the last 18 months, we're starting to see more creative solutions like this. But would you like to speak to if an employee's on a drug like that?
Yep, so let's say you're taking a Skyrizi injection every 6 weeks. Right now, through a traditional PBM, that injection pen is $21,000.
Every 6 weeks.
We source that same drug, and so I'll talk about the sourcing we use. We utilize 340B pricing, which is federal pricing at the 340B level. And then we also have direct relationships with the pharmacies in Canada. And so what we do is we just redirect the purchase of that Skyrizi pen to come directly to your house from, you know, most of you today get things delivered to your house on a regular basis, so it's not, 10 years ago, it was very difficult to talk to people about getting things sent to their home. It was kind of scary. Like, hey, I don't know if I want people sending things to my house. Now we have it done every day. And so what happens is that drug is sent to you, whether it's every 6-week fill or every 90 days, it's just simply mailed to your house, directly from the pharmacy, wherever that may be, directly to your home. It's a better experience. You don't have to, go fill it in the middle of the winter here. When you need it, it's just gonna be mailed to your house. And again, you'll call our 800 number if you have concerns like, hey, it's where the tracking is of that, you're gonna be able to know that where it's at, so there's no concerns of ever missing a fill. If, for example, the dog ate it, which happens when you put things on, is we then allow you to just go get a domestic fill while we fill that order for the next month. So when mistakes happen or things happen, we have quick ways to resolve those issues. If for example, that for whatever reason that didn't show up, then you can just run up to Walgreens and fill it traditionally like you have in the past. Infusions were a big thing. So what we do is we move a lot of these things out of the hospital setting and into the RX side, like an infusion. And so when you have that done at a hospital, it's billed through your medical plan. But when you have it done by a home health nurse, we bill it through the pharmacy side. And so we're able to take that facility charge, and I'll use one, Kansas, the University of Kansas. We have a cancer patient, stage 4 cancer. They're receiving an infusion for $138,000 every 6 weeks. We're now filling that for about $13,000 by a home health nurse. They were driving 3.5 hours each way to KU to have that infusion done. The exact same infusion, the molecule, is now done at their own home. They don't have to travel. Now it's billed on the RX side, and we take that whole facility fee away from there. They're actually getting just as good a care, if not better, and they're saving, a full day of, anybody that's getting an infusion isn't really feeling like driving 3.5 hours, in there.
And I'll just add that these conversations that we're having, like in a situation like that, it's really important to take that 130,000 and bring it down to 13,000, because at the end of the day, next year when it comes to renewal, what do our rates look like next year? This time next year, what do our rates look like? It all depends on that scenario right there. Because if 130,000 is hitting your guys' plan every 6 weeks, well, the stop loss carrier, the one that is the ultimate, and self-funded, there's a stop loss carrier. So the county assumes a certain amount of liability. Let's just, for a simple math, we'll say $1 million. We're willing to take on $1 million of cost. After $1 million, we don't have the budget for it, so we need somebody else to come in and cover the rest of it. That's a stop loss carrier. They cover everything above that $1 million. Well, that costs money, because that's a lot of risk. What happens if you have $5 million in claims? You guys pay 1, they pay 4. So in order for them to take that risk on, they charge a premium for it. That's what makes health insurance go up every year. So if we're doing a bunch of 130,000 claims every 6 weeks, then next year's renewal is not going to look good. They're going to say, you guys are way too high cost, we're going to have to charge more. But if we bring those down to 13,000, when everybody else is paying 130, our claims experience looks lower than it did this year, than last year, than the year before, and we're going to get more favorable terms when it comes to renewing with those insurance carriers.
Ian,
Yes.
is that one of the drugs, early in your presentation, you talked about $300 and above would be at no cost to the employee? Would that be one of those?
That would be one of those.
Okay.
So that would be no cost to the employee. So
Even,
now the employee
even
doesn't
though
have
we
to-
got it down to 13,000, it's still no cost to the employee.
It's no cost to the employee. It's still going to hit the
Yeah,
plan,
yeah.
but it's no cost to the employee.
Okay, thank you.
Yes, great question, fantastic question. So that's why that's really important. That's why we have to put these cost containment strategies in place, because we need less claims over the year. Even if the claims are still the same, we can't stop people from getting the treatment. The claims are going to be the same. It's what is the cost that we incur with those claims. Right now, there's not a lot of advocacy for those claims. We're getting 50%, 15% discounts. We need higher discounts. And so, the only way to do that is to pay a substantial amount of money more and move to a Blue Cross that's got really strong discounts nationally, but they're gonna cost the plan, an additional $1.5 million. That doesn't make any sense. We're just taking those, now we're getting higher discounts, but we're paying more for it. So Applos is a fantastic solution for that.
One other thing that Pharos, the contracting team, that they utilize is they're Kaiser Permanentes, they're some of the Blues, others, they negotiate all the air ambulance and ambulance contracts for some of the most major carriers in the country. And so they actually employ pilots to actually figure out what the rate should be for those air ambulance charges, because you can see a huge sway for an air ambulance charge. And I'm sure from here to Fort Collins, that's not a cheap helicopter ride. And so you want somebody on your side really looking at what those costs are and making sure that you're being charged correctly for those.
Yeah, and, no, I think with that said, yeah, I mean, in terms of, I guess the last thing I'll touch on, and then I'll open it up to any questions. The other thing that we want to improve this year is employee experience from the benefits enrollment side. So this year, and I don't know if communications have gone out yet, but they probably will here soon. In terms of open enrollment, we're actually going to have licensed, non-commissioned W-2 employee benefit advisors that will be available to meet with every employee that can go over anything with them. So it'll be a private setting, one-on-one setting between that employee and that benefit advisor, where they can talk through their health situations. They can ask, for advice on how they should handle their medical expenses throughout the year. Should they contribute to an HSA? And that goes above medical. It's also, that includes the dental, that includes the vision, that includes, even accident plans or any supplemental medical health plans. They'll be able to meet, every employee will get the opportunity to meet with a licensed health insurance benefit advisor and walk through kind of what this change is going to look like for them. So if you're an employee that is one of those high cost, you have one of those high cost drugs, it's a great opportunity this year at open enrollment to be able to sit down and say, hey, this is what my experience looks like now. How is it going to look with this particular plan? Should this be the route that we move? So that'll be an improvement this year. It's just that level of education that employees are going to get this year is going to be hopefully the best that it's been. We've also put together, with the help of Lisa and her team, they've been phenomenal in this, just working together to try to strategize on how we can make this experience better. We've put together a robust benefit guide that will be available this year that has information on all of the benefits that are offered as a Scotts Bluff employee. And it's in one place, and you can access it in 5 different spots throughout the year, and you'll always have access to that in case you wonder, how does this work? I can't remember, how do I file a specialty prescription? Like, where do I go with that? What's my vision benefit? Things like that. That'll all be available in a benefit guide to all employees throughout the year in an easily accessible way. So that's new. And then the last thing is we're currently in the process, and we've been working on this for a while with Lisa, Charlotte, Kim, on bringing you guys into what we call a benefit administration system. So right now, a lot of the stuff being handled is all in Excel files, and it's all on paper. The enrollment process is a lot of paper. It's a lot of manual entry from the admin team, and bless their hearts for doing the hard work on that. And this year, it's being put into one place, so a benefit administration site. So all employees, anytime throughout the year, will have access to their own portal, benefit administration portal, where they can go, they can log in, and they can see exactly what benefits they signed up for. So you can, if you want to, and if in June comes around, if you're anything like me, I forget if I even signed up for vision insurance. So if June comes around, you can log into your portal and you can see, okay, I signed up for family vision, or I only signed up for employee and spouse, or whatever. And you can, or you can change your address, or you can just see, like, maybe I want to file a claim on an accident claim. Well, you can log into that portal, access all your benefits and everything, your forms, all of it's right there. So we're making the benefits more accessible than they've ever been, hopefully more transparent than they've ever been, as well as trying to educate so that employees know what they have and how to use it. And that's pretty much the end of the elevator pitch. Long elevator ride. Any questions on that? It's a lot of change.
You know, one thing I don't think we touched on, how do you handle pre-existing conditions when we convert everything over to a new company?
Yeah, so, well, there are rules around that. It's a great question. How do we handle pre-existing conditions? So, well, by law, nobody with a pre-existing condition is exempt. So there's no exclusions whatsoever. Those with pre-existing conditions, when it comes to the treatment they're receiving and, you know, where they're getting those treatments facilitated, as well as the prescription drugs they're on, or infusions they're on, all employees going through those types of, going through current treatments will be reached out to, and we'll have a discussion prior to 1/1, because this is all a January 1st effective date, right? We're still on the current health benefits until January. So from now until, you know, should this be the decision to move forward, from now until January, every employee that's going through something, whether they're experiencing, or whether they're getting treatment or going through a course of treatment at a certain facility, they will be reached out and they will be explained, you know, here's the process, how it's gonna work, and they'll be put on whatever that treatment path looks like. BJ, you wanna speak to that?
Yeah, so we get a data feed of, it's called a transition of care report. And so we get the transition of care report, we're gonna see, they're not perfect, by the way, so when we're doing open enrollment, we wanna, you know, if somebody has a concern or they've got a back surgery coming up in early January, we just wanna know about it so that we can make sure we reach out to that, facility, make sure that the financial model's put in place before that so there is no disruption. Sometimes we don't get, the carriers sometimes aren't great at these transition of care reports, we'll be honest. And so when we get them late, our team just jumps on it really quickly and you know, we especially this one's self-funded, so we'll have better case management notes, so we'll get a lot more information than we would from a fully insured, moving from fully insured to self-funded. But those transition of care, the RX is really simple. The hard ones are sometimes people have some procedures that either the TPA hasn't taken great notes on, you know, keeping track that this procedure is going to happen. And so we want the members to also tell us, like, hey, do you have something coming up, so that we don't miss it in case it's not in the case management notes after the TPA. Questions on that?
No, I think it sounds real good.
That's
It
a really
all
good-
sounds good going in, we'll see how it is coming out.
Yeah, I mean, it's, what really is hard is if we don't know about it and it's January 2nd and somebody's standing at, the University of Denver and, they're calling us, so we're gonna make sure they're taken care of, but that's what we would call disruption, is somebody's standing at the office, they've got a planned surgery, nobody's been notified, and it's just communication. And so what'll happen is we have about 110 people that are, this is their job, is to then reach out to that facility, make sure that they show them that they have coverage and make sure that there's no disruption.
Can I ask you one more question? Now, you're talking about using a lot of home health care, is that right? A lot of procedures you're gonna try to do at home rather than,
No, just really the infusions.
just the infusions
Yeah,
only?
so
I misunderstood that in the beginning then.
Yeah, no, just for infusions. So many infusions now can be done on an outpatient basis. And it's actually better, the member enjoys it more. And so, all the times it's kind of a battle between the hospitals and the health plans. And so right now infusions are kind of a big moneymaker for the hospitals. And so, we know that. And so we're able to keep the costs down for the health plan by having those.
So who do you hire to come out to do those?
I haven't looked at the home health nurses.
Is it a
here.
it's a home health you use basically?
Yeah,
Okay.
yeah.
Remember the hospital just transitioned out of home health and they use Brookstone,
Oh, no
you
kidding.
know?
Okay.
And if home health isn't an option, they'll still go to a facility for those infusions. Yeah.
Okay, just so
It's
we're
just where
covered.
it works.
Yeah.
But most of that is doctor oriented anyway. I mean, you have a procedure, you have a knee replaced, whatever, and they know that you can't get back and forth to rehab. The doctor will prescribe a home health nurse or a therapist to come to your home, and so that's, yeah, it's
Same kind of.
Yeah.
same kind of deal,
It's
yeah,
just same concept.
right,
Yeah.
right.
So give me 2 or 3 examples of infusions, like what?
You now can have infusions for all sorts of things, malnourishment, cancer treatments.
Cancer treatments,
Uh,
that's what I wondered.
Lots of different treatments now are infusions versus a pill. So it'll be more of a saline molecule that goes into you, because there's advantages of not taking it orally, but it's done
Like
via
an IV.
An IV. And so there's just a thousands of different things that are done by infusions now that used to be either orally or it was injection. And so those infusion bags are in that IV the exact same way you would in a facility. And then if there isn't a home health nurse, then we look to outpatient facilities, because then you don't pay the huge facility fee for that infusion.
Okay.
The list is so long, I don't know if I.
That's
but-
good enough. I was assuming cancer treatments, but I wasn't sure.
The other thing I wanna, I think a really good reason why we looked at APLOS is their average claim payment, so when they pay a provider, is roughly 6 days. There are still claims, in the current setup with the current TPA from a year ago that haven't been paid. That's a scary thing, and it's nothing, it's nothing you guys can do, nothing the county could do about it. They're not in charge of paying claims. We rely on our TPA to pay the claims. But sometimes between a provider and TPA, it's not uncommon for 6 months, 8 months, 12 months to pass, and a claim hasn't been paid. The employee doesn't know any different. They're just paying they give them their card, they pay their deductible. But from a county perspective, when it comes to budgeting and it comes to these overall numbers, you guys are self-funded, which means you're taking on the claim risk up to a certain extent. How do we budget for next year if we're still worried about what's coming from last year? Because Lisa and her team, they don't get the claim to pay. They don't get that number until the TPA sends it over. Well, if it's a year later, we didn't put that into our prediction model because we didn't know about it. So if we're worried about what's happening last year, and we're trying to predict for what's going to happen in the future, that's tough. So paying those claims quickly, resolving a claim in 6 days on average, is really big for us from a self-funded perspective, because we know the claims that are being incurred a lot quicker. We know when it's happening. We're not finding out that there's a high cost claim a year later. We know right now. We know that drug is expensive, and we know that we need to put a procurement strategy in place to contain the cost. So that'll be really big into overall lowering this cost and getting us into a better position next year and the year after and the year after. But yeah, that's. Is there any questions outside? These have been fantastic questions.
This might be a question for you, Ian, or I don't know, Lisa. Are there any current counties in Nebraska who are under the APLOS, made the transition similar to what we're doing?
I know you've got I don't want to speak for Apples. I don't believe so. I know there's some Missouri ones that you guys have, and you've got some Oklahoma ones going live right now. I think Nebraska were the first. Scotts Bluff would be the first under APLOS specifically, county-wise would be the first. There are counties in Nebraska that utilize the kind of methodology that APLOS uses, just not under APLOS' umbrella. There are other providers out there that that have similar concepts that their counties utilizing. But no, I would say for the most part, the smaller counties in Nebraska are being serviced by the Nebraska Association of Counties, NACO, and their pool, which I have a lot of experience with and just wasn't competitive in this situation. But no, good question. You guys will be the first.
So can you speak to, say, going forward, the board here approves it, what does it look like as far as then starting negotiations with Regional West, Morrill County, Torrington, the Front Range hospitals that a lot of folks here?
Good question.
Yeah, so just to kind of go back, so Pharos, they're about a 27-year-old company. They got started in Amarillo, Texas. They negotiated work comp claims. So if you're familiar with work comp claims, you want to get those settled really quickly, right? You want to get them done. So they started 27 years ago. They had the Amarillo minor league hockey team as they started doing this for them. They did such a good job. They got the entire league. They do this for every professional sport in their minor league affiliates, with the exception of a couple of NBA teams. 95% of every Division I athlete, Pharos and Akinet work out and establish the contract with the provider. So if I'm Rayola and I get hurt and I gotta go to Nebraska Med, it's actually Akinet, the same people talking about your claim or talking about Rayola's claim at the Nebraska Med. And so we have about 110 people that reach out and make those contracts. So we most likely had experience at every one of these facilities when we did it. We did no pushback. We've had great experience with any claims that have been at these facilities. Now, as the population grows, let's just say we have not just the county, but then a bunch of other employers come in here, we would get what's called an alliance contract, which was kind of an overarching umbrella contract that covers that, for everything. Before then, what we have is what's called single case agreements. So they call and get an agreement in place with those facilities, and they do that on a, every hour of every day. And then as we get more patients there, those all turn into long-term single case agreements. So there's agreements in place already with patients. Then what we get is what's called long-term single case agreements with that facility for all patients, if that makes sense. So similar to like Mayo Clinic doesn't sign long-term single case agreements like we would with most of these facilities. They want every one of them to be an individual contract. That takes more time on Mayo's part. So most facilities will just do a long-term, so they don't have to keep fooling with it, right? They don't have the staff to keep having those conversations, and so that's what is going to happen. Is that team will reach out, get that settled, and have a contract in place. So now you went there, and now the next 5 patients have that same agreement.
So I think that would also help answer that question is, let's say the care transition report comes to you guys and you see that an employee is needing a surgery in 2 months at a specific facility. Before 1/1 has even come up, so before January has even happened, I assume your team is reaching out to that provider on that particular surgery and establishing a contract.
We used to. We now only reach out about 15 days before because the hospital itself doesn't want to talk about something that's 2 months from now. So they're like, call us 2 weeks before and we'll get it in place then. So we used to do that. We used to call like 3 months before because somebody, is concerned about it. And the pushback was always from the facility saying, can you just, we don't even think about that, until 15 days before the procedure. So we now reach out about 2 weeks before the procedures because they don't even.
So 2 weeks before each procedure, you're contracting that case agreement.
Because anything before that, they're like, there's so many things that happen on these procedures. They get delayed. This person, it's 2 months out. They're just like, wait to make sure it's gonna happen. That right there is the difference between between the current setup, between a reference-based pricing model, and then between Outpost, is the fact that they're doing it anytime in advance. So 2 weeks in advance, they're reaching out and they're making the contract for that procedure. Generally speaking, that employee goes and gets that procedure done, and then all the negotiating happens after that. And that's where it could be a negative experience. Procedure's already done. So the leverage that you as an employee has to be able to go someplace else is gone. They did the work. So if you think they're gonna cut their prices down after the fact, they're not. So doing that 2 weeks in advance is what gives them more favorable discounts. It's that proactive approach that's getting those discounts.
So, a couple questions and observations, I guess. So, Apollos is still a self-funded plan, so to speak, and you're still a third-party administrator type situation.
Yes, it's a self-funded plan because there's still stop loss.
Uh-huh.
So in the event these claims, every single employee at Scotts Bluff gets unhealthy. There's massive outbreak of some really bad disease, puts everybody on a ventilator. In the event that something like that happens, there's still a stop loss carrier for that worst case scenario that's going to cover that, so that you guys have a maximum liability. That you will not go above a certain number. That protects us from a maximum Right, and then there's still a TPA. Applos in this case is the third party administrator, and then there's still a pharmacy benefit manager, which is VividCare RX, which is the same PBM, pharmacy benefit manager, that like Hy-Vee uses, and they're 30,000 employees, so very large PBM.
So at least based upon explanation, what I'm understanding from Applos is that that you have an aggressive plan in place to help reduce costs. And,
Yes.
and without affecting services or coverage for employees, is what I'm understanding. And then I'm assuming that aggressive approach of reducing costs then ultimately reduces the cost for us, or at least keeps it in check. And that the I guess, so the simple question, well, let me ask this first. So what I'm hearing is there is no less coverage than what we have now. Would that be true? I thought I heard that.
Yeah, employees will still get coverage to the things that they're going to, the same that they have now.
Okay.
Nobody will not be able to get a procedure covered or their services. Yeah, no one's gonna lose the ability to seek coverage.
And then I thought I heard you use the words, or a list of better coverage. Did I hear you say that, or did I not?
And in some cases, yeah. I mean, it's gonna be, it's all perception. And so, like in the case of in-home infusions, a lot of people would consider that better coverage. The fact that I don't have to drive 45 minutes to Torrington, sit in a hospital bed for 45 minutes. I don't know how I'm gonna feel after that, and then drive back. I get that done in the comfort of my home. In most of the cases, that's gonna be a higher satisfaction.
I think so traditional PPO, they don't put in cost containment solutions. Their whole thing of a PPO is stand for preferred provider, but there's really no preferred provider, right? So what we really look at is, let's say somebody's gonna have a transplant. Unlike the PPOs that just see who's in network and then you go there, we have a whole clinical team that's gonna look at that, and maybe this particular transplant, the best in the world is at KU Med. Just as an example, those are things that we're gonna reach out to that patient and say, hey, this is an option for you as well. Here we have KU Med, the #1 transplant provider in the country, is there. Would you rather go get your transplant there? Because maybe their local provider is just referring them to somebody they know. Who is it? Because when you get something like a transplant done, if it doesn't go right, that's when the cost of that transplant goes through the roof, right? Trying to fix something that's broken. And so I think one of the things that we do better than the PPOs is say, okay, Mr. Harris, you're gonna need a transplant. Here are some other options if you would like other options, because this one's only done 3 transplants in their whole history. The other one does 3 every day. So where would you rather go? And those are things that our clinical team are gonna reach out to those members, because we ultimately want that transplant to happen and be successful. So those are some things that we do on our end to try to enhance that benefit.
95% of you will consume health insurance the same way you always have. Because again, 5% of the population is what's causing 90% of the costs. That's just everywhere. That's just how it works. And so for the majority of the employees, it's gonna look and feel similar to what they're already used to. We just hope to bring efficiencies to the table in terms of quicker access, like with virtual care, being able to have that additional option at everybody's fingertips, and being able to procure those drugs that are over $300, have them sent directly to the house and cost nothing to the employees. So for the majority of employees, or employees who don't ever go to the doctor besides 1 or 2 times, they're gonna just go to their normal physician, and it's gonna be like it always was. But it's those high costs. The strategy is cost containment. So it's around the high cost claimants, it's around prescriptions, the pharmacies, the infusions, and then those really, really high dollar medical procedures. And how do we put strategies in place that keep those in check. That's ultimately what this is establishing and doing.
When the insurance committee first met with Ian, I think we did it over Zoom or,
Yeah.
I don't remember. Everybody was really impressed with, first of all, the longevity of Alliant and how long you guys been in business, how many counties you're dealing with. I think it was 70 or something like that in Nebraska.
In Nebraska, yeah.
In Nebraska, 70 counties that they deal with. And it was, the whole committee was impressed. I know Lisa was impressed. Even myself, I've sat on insurance committees for a number of years. But the thing that impressed me is the fact that their job is to find something that's better than what we have now. And that's what he's done. That's what they're presenting to us. As far as the third-party administrator, when they first started, they were it. I mean, everybody used it, but that's not the case anymore.
Yeah.
And what Ian's job is to go out and find the APLOS or whatever it is to bring it to us and say, this is going to be the best for your organization. The other thing that I was impressed with was the amount of work that they did on our claims and telling us that we're 1.4 million or somewhere. That we have the chance of losing all of that. And they're saying, I think we can fix that. That's what was impressive. That was impressive. And
Thank you.
as I said, I think I don't see any other committee members here from the insurance committee. Oh, there she is. I was impressed, and I was assuming you were too. When they got done, we were looking for the papers to where to sign, you know, to get it to take
Yeah,
care
and
of.
thank you for that. What I'll say is,
I think Nancy wanted to say something,
oh,
So I have a question about
Yeah.
this. So if somebody is undergoing cancer treatment right now, you were saying with the infusions and stuff, they would do it at the home health. What if the doctors, do the doctors agree to that usually, or?
yeah, that's a really good question.
So we have it in the plan language that if it's medically appropriate to have them, most providers, whether we like to admit it or not, want to make more money, right? So we have to have the plan language to support if it's something that's commonly done in the home, that we want that to be done in the home if appropriate. Everything is an exception. Ultimately, it's the county's money, and if you guys want to make an exception for this one member to just don't keep having them go to a certain facility to have that done, we have no problem with that. We just want to make sure we have the plan document in there to support cost containment if medically appropriate. Because that KU doctor that's getting $130,000 every 6 weeks does not want to see that patient leave. Right? So we have to have a plan document support that the plan wants that person to be in the home. And as long as your insurance committee supports that, then we would, but always it's a self-funded plan, so really you can make any concession you ever wanted to. We just want to support you if you want to make that person happy.
BJ, how does the stop loss carrier factor into that then?
So they're gonna cover any medical necessity they're gonna include in that, so
They wouldn't.
they're not going to,
Okay.
they're gonna want us, they don't wanna have an aggregate hit, and so they're gonna like it in that, they're gonna want an explanation why this person isn't getting an in-home infusion when thousands of other people are for that same.
Exactly.
Yeah, they're gonna be in favor of. and-
Yeah.
Yeah. they're
Cost
gonna want the
containment.
cost down as much as they can. But if it's medically necessary that that employee receives that cancer treatment in a hospital facility, they're gonna get it, so, yeah.
And you said the drug, if any drug is over $300, that it's zero cost to who picks up the cost?
It still hits the plan,
Okay.
but why it's the incentive to the employee to make this transition is that it's gonna be a little different, cause they're probably used to going and picking it up at their pharmacy or whatever, and now it's gonna come to their house. And maybe so some people, they're gonna love that, some people might not like that, but the incentive to the employee is now it's free to you as an employee. The reason we're doing that is we're getting that drug procured at a much less expensive cost, so it still hits the plan. The county's still paying for it, but they're paying a lot less for it. So it works out in everybody's favor. Employee pays nothing, county pays way less.
In rural areas like this, we have some people that say, hey, can you use them at send? There's certain, they live, kind of where nobody, or they just don't like people on the property, whatever it may be. So when we say to the home, that's kind of a broad brush. It could be sent to their work, it could be sent, to a family member, and they probably already have that in their files as well. So I just wanted you to, these aren't strict things that you have to be done. So if it's, somebody's transient or they're between homes or whatever it may be, we're gonna work with them to send it to where they most appropriate.
So the pharmacy things, are they comparable then, like with the Mark Cuban Cost Plus kind of stuff?
Yeah, so what Cost Plus does, and it's great, I'm not dogging on it because it's important, but what Cost Plus does is those things that don't hurt the medical plan from a cost perspective, your amoxicillins, the stuff that's gonna cost $10 by itself anyways, they're getting it for $2. And that's great, that is, it's saving money. But that's not doing anything for the Himeras and the Manjaros and the things that are costing $100,000, $200,000, $300,000. So it's a similar concept, just on the specialty drug basis. So taking advantage of those high cost plans. Yeah.
I have a question. I didn't get your first name.
BJ.
BJ, that's right, okay. I
That's easy.
didn't bring my hearing aids tonight. Okay. How is catastrophic coverage and reinsurance work in all this? You lightly touched on it, but I didn't get enough information to cover what my thoughts are.
So Nationwide is the stop loss carrier. You have thresholds, and apologize, I don't know the specific here. So you have a spec deductible, so each claim is
$80,000
$80,000 spec, so anything that on a specific diagnosis, it's $80,000, and then you have a aggregate deductible, which is $1 million.
Oh, I don't know.
So your aggregate is your total deductible, and then once you guys exceed that, then Nationwide starts paying for any claims above that.
Okay, so it's all covered to who knows what, huh?
Yeah, you guys are rolling the dice that you're gonna take on a specific amount of risk. If on an individual employee, that's specific deductible, that risk might be 80,000 or is 80,000, and so then if that person has a claim that's above 80,000, everything above 80,000 is covered by Nationwide. On an aggregate level, so across the entire plan, there's a specific amount that you guys have a threshold of. If it goes above that, Nationwide covers the rest. The beautiful thing about a self-funded plan is if it goes below that, it's a surplus that's maintained by the plan. And that can be put away for future years that aren't as healthy or aren't as positive, or to help offset costs. Now, unfortunately, in the last few years, there's been the opposite, a deficit. Hasn't been a surplus, you guys have went, you've had higher claims than expected. And a lot of that comes to, again, if we go back to delayed claim reporting, and just honestly, I'd say most of it comes back to the data, right? You can't really predict and budget effectively if you don't know what's coming. And so, in the last few years, it's been a rough, there've been some high claims. You guys, it's been a very unfavorable, the numbers have been unfavorable. What we hope to do this year is have more favorable claims experience. Even if the claims remain the same as they did last year, if we're getting a 70% discount on the average amount of services versus 15, the claims experience itself is gonna drop significantly in terms of dollars because the discounts are higher. So ultimately, we should have better claims experience next year in terms of dollars incurred, claims dollars incurred. These are really good questions, and you guys are asking the right questions and you're thinking the right way.
I wanted to touch on just one more thing. So the cancer infusions, when we talked about those, we know with some of the claims, you have some folks here that have infusions that we can't move. Meaning it's very medically necessary to be in a hospital to have that infusion done. In those scenarios, it's just, they'll consume that healthcare no differently than how they did before. And so, we kinda throw out that home health, because about 90% of them, it's simply an infusion that can be done at home, but about 10% of those infusions, we can't have them change their setting, like in the hospital. And same thing with the specialty drugs. When you get prescribed a high-cost drug, many times you'll get what's called a short fill. So you'll get it for 2 weeks to just see how your body responds to that short fill. And then they'll give you a 30-day fill. So we don't get involved on the short fills. Those will just still continue the way you would consume them today. And then once your body, everything shows that it's gonna work, that's when we'll do the mail order and send them to your house. But when you do the short fills, we want that to be really a doctor-patient oversight on those short fills.
So do we have any idea on like employee deductible premium?
Plan design
Any
is
of
gonna
that?
stay the same as it was last year. So in terms of the actual plan design that an employee has, fantastic question. As far as I know, unless that's changed, same exact deductible, max out of pocket, all of that.
With the exception that the federal government increase the deductible to 3,500 rather than 34?
Yeah,
Yeah.
yes, to be HSA eligible.
Yes.
Yeah. Yeah, so the plan design is gonna be same as it was last year. You're gonna have an HSA that you can contribute into if you want. As far as I know,
At this point, we aren't looking to change our premiums.
okay, premiums are the exact same as well.
Okay.
So,
Thank you.
yeah. Really good question.
Last time we talked, you said you weren't sure about dental or who was gonna handle that.
Still talking about that.
Still okay.
Yeah, we're looking at a couple of options, and we discussed it just last week, and Ian brought some stuff, like today, so a little more time,
Almost got that buttoned up.
yeah.
He's doing what he promised he was gonna do. And that's go out and find the best plan for us.
Yeah.
It takes a little bit of time.
Yeah.
It's a lot of negotiating, but
So,
it's fun.
We do appreciate you guys being here today and coming out and discuss things with us. Lisa, are you gonna give us then, where do we go from here? What's the thought process and the
that we need,
procedures?
as far as we're ready to move forward with this, but it's on your agenda tonight to approve, okay?
And the
So-
insurance committee has given their recommendation to do that.
Yeah,
Okay.
yeah, to move forward, but we just wanted to do the formal presentation, make sure you'd seen it, and some of them are seeing the formal presentation today, as are we. And then once we get the insurance proposal approved, we are going to start enrolling people for open enrollment, which is supposed to happen in 2 weeks. Every employee, at least the ones that are on it, well, every employee, even the ones who aren't on the health plan, right? Will need to meet with an advisor. So you'll wanna sign up for your appointments earlier rather than later, and they're gonna be scheduled for like 30 minutes at each of the different locations. We're working that out, and we'll let the employees know how that's going to roll out, so.
Where will
But
those advisors come from?
They're gonna be virtual. They will be,
Virtual
we will have a couple different workstations, sorry, I keep playing with my
Yeah,
microphone.
I'll be out here to assist with questions and stuff, but,
You will?
yeah.
Oh, okay,
Okay.
I didn't know that.
Unless you guys don't, I mean, I get it after this long of a talk going
No,
out.
no, no, you're all good.
No, I do wanna say thank you guys for letting us come out here, for letting us present, and for letting us work on your behalf. You know, it's a lot of work, it's a lot of back and forth, it's a lot of, you know, some unfortunate news sometimes, and we can only do so much with the data that we're given, so really appreciate it. And I know, Lisa and Cam and Charlotte have been absolutely phenomenal to work with on this, and they're in a thankless role a lot of times, so really appreciate you guys. And this whole time we've been doing this, the current insurance and the current claims, that doesn't stop, that still happens. So I've been taking so much of their time just trying to figure out how we can put something in place that's going to treat these employees well and put us in a good spot. All while doing that, we're still getting claims coming through from previous year and working with the last TPA and arguing and fighting over who's responsible for what. And so it's just been, I just appreciate you guys for that. Appreciate you guys for the support and the insurance committee and everything.
And it has been very helpful to have Ian and his team help. There's been a couple issues with our current TPA that he's helping me get through, because it's not as good as it's been. And we need some help getting through some of the hurdles that they're charging us for, so.
And the last thing I'll say, and I know it's weird because they're sitting right here, but I don't work for Applos, and I work for the county, and I work for the employees of the county. And so next year, if there's a more favorable option, we're gonna go to a more favorable option. So it's not to say that this is the forever plan. While I appreciated them saving us in a bad year, and we hope that it's gonna be the most favorable option, we hope it's gonna be a great experience, and it's gonna provide us what we need, and that every year they stand out on top. But with that said, this time next year, if they don't keep their pencils sharp, there's gonna be other opportunities.
Well, either that or you get Raiola back on the field next week. I don't know what you need to do to get that accomplished, but that would be very appreciated out here.
What was the statistic you gave us, BJ? BJ played for Iowa State the year that Iowa State beat Nebraska, and Tommy Frazier was on the
Who played?
right?
I did, yeah.
Yeah, VJ did.
Really?
Good.
Yeah, I was a freshman, so I just ran down on kickoff, so I didn't have much to do with it.
BJ,
Okay.
does your company give any, non-tobacco use discounts on any of these, or is it all just about across the board? How does that work?
We were just talking
Yeah,
about
so,
this.
so Russ, you guys have that $80,000 spec deductible is for each individual, so we don't,
I mean,
that
I'm
is-
just talking about the, on a payment or,
that's all up to you guys.
That's a county decision.
Oh,
So
alright.
we have some counties who choose to, if you're tobacco free or you go through a health exam, they'll choose to lower the premiums, and then we have some that treat everybody as unit tobacco, everybody gets the same rate.
it seemed like every place that I've ever went and got insurance, that was one of the questions on there.
If you're a tobacco user, well, yeah, that's definitely something we need to know just for purposes of, how healthy the plan is, but it doesn't necessarily impact rates.
Okay, I didn't
Unless
know
you
if it
wanted it
changed
to.
rates or not.
Yeah, that's
You're
just a decision
self-insured.
that's made.
That's definitely a difference for self-insured, right?
I guess.
Yeah.
I'm learning, I'm just trying to learn.
Yeah,
I know,
no,
it's a
there's a
good
lot to
question.
it.
Good
There's a lot to it. Anything else? So we got, we're scaring people off.
Yeah.
About the time. Yeah.
All right. So, not seeing any other questions or discussion. And there has been a recommendation from the insurance committee for, to go with this plan. And then any other discussion from commissioners?
Steve, you got one of the bigger departments, how are you with what you heard tonight?
Oh, yeah, I'm sorry, Steve, you're on the committee. I said, I didn't even,
I don't see any downfall.
he was sitting right there.
All right. I don't know what your thoughts were.
Okay.
It was very favorable. Every time we met, every time Ian was either on us with a Zoom or we had information or material, it just got better and better and better every time we got together. So it was,
Doesn't always work that way, but it did in
Sure.
you guys' case. Yeah, and that's what we aim to do.
Okay.
Every time, so, yeah.
Any other discussion? And if not, I'd entertain a motion.
You'll be voting on it, at the 4:30 meeting.
not,
Right.
Oh, we don't vote.
Right.
it's not on this
Yeah,
agenda.
not now. It's on the other agenda, I believe.
Yeah,
I'll give you a motion to
so
adjourn.
you'll have to stick around.
I'll give you a motion to adjourn.
Well, so on this item, it appears that the discussion has ceased. I see on this agenda, it talks about public comments. And, Board of Commissioners will receive public comments on items discussed at this meeting or suggestions for items of discussion at future board meetings. The board will not take action on comments presented this date. Is there any public comments this evening? All right. Seeing none, then, and there's no other business, the meeting's adjourned.
Hey, Russ,
3:50.
as much as you and I cook, we really need to talk to Ian about those Fairbury hot dogs.
Really, you can get us some of those, you think?
The very best hot dogs in the world.
I disagree, after you've been raised on them,
Is that right?
yeah.
Really? I thought you'd be a real proponent for
No,
them.
I always make the joke though, because they say red dyes, creates all these problems.
Yeah.
If you ever want to know, you just take a population of people from Fairbury and use the pest.